me for this conference. So my topic is thyroid function tests and how to interpret the results. As we all know, Dr. Sen in his earlier lecture had shown some cases of thyroid where there were some issues, and it's a complicated subject because there are 3 hormones, 9 different outcomes, and we'll try to simplify as much as we can, and we'll try and play a game in the end. So as we all know that thyroid is the second most common endocrine problem after diabetes, and how we interpret it is very important. So the thyroid has basically a feedback loop. The hypothalamus secretes TRH, which stimulates the pituitary to secrete TSH, and TSH in turn stimulates the thyroid gland to release T3 and T4, which then have a feedback inhibition back to the pituitary to reduce the TSH. This is how the feedback loop in a thyroid hormone functions. So as TSH is secreted, TSH stimulates the thyroid to secrete the T3 and T4. They are secreted in a molar ratio of 14:1. That is, for 14 molecules of T4, only 1 molecule of T3 is secreted, but 80% of the circulating T3 is generated in the periphery. That is, the T4 is converted to T3 using this enzyme called 5-deiodinases in the periphery. So as you can see, T4 is more protein bound compared to T3, so hence more of free T3 is available. So the free forms of both T4 and T3 are the active form. The protein bound forms are not the active forms or the inert forms. So since there is more free T3 available, it is more physiologically active hormone. Secondly, the half life of T4 is 5 to 7 days and T3 is less than 24 hours. Hence T4 is preferred for replacement therapy because a single daily dose can be given. And as I told earlier that T4 is secreted 14 to 15 times more than T3. So what are the actions of the thyroid hormone? They regulate carbohydrate, lipid, protein metabolism. They help in CNS activity and brain development, cardiovascular stimulation, bone tissue growth, GIT regulation, sexual maturation. So pretty much all organ systems are affected by the thyroid hormones. So these are the biological reference interval of thyroid function tests. We all know them, but just for clarity, TSH is 0.4 to 5, FT4 is 0.8 to 2, and FT3 is 2.1 to 4.4. My source is Teach Clinical Chemistry, but most standard textbooks will have values pretty much similar. TSH, primarily the secondary hypothyroidism cases where the hypothalamic pituitary is involved. In such patients, TSH may not be reliably indicating the regulation of T4 replacement and therefore may require estimation of the FT4 levels. So in patients whose TSH levels are elevated, we then do the FT3 and FT4 level, but primarily the FT4 would suffice. So FT3 and FT4 are preferred over total T3, T4 because these are free forms and these are the only active forms. In conditions where thyroid binding proteins would either elevate as in pregnancy or decrease, T3 or T4 levels could be falsely elevated or reduced, thus giving a spurious diagnosis. So according to American Association of Clinical Endocrinology and American Thyroid Association, these are the guidelines for using the various thyroid hormones. TSH alone should be used if hypothyroidism is suspected. We should use FT4 and TSH only if hypothyroidism is suspected for routine examination. FT3 should be used in cases of T3 toxicosis, which I will discuss later. And for follow-up treatment on patients on medication, only TSH should be used. And as I said earlier, we should not order total T4 and T3 for the reasons that were obvious. So since TSH level change dynamically in response to alteration of T3, T4, the initial approach is to test the TSH levels only. Currently most of our CLI analyzers are doing 4th, 5th generation assays which can detect TSH as low as less than 0.0025. but for all clinical purposes, a value less than 0.1 mu per liter are considered sufficient. So this is the classification of hypothyroidism. You can primarily classify them into primary and secondary. The primary can be due to enlarged thyroid, normal thyroid, post-ablative and congenital hypothyroidism, and the secondary or the central hypothyroidism is primarily due to the pituitary hypothalamic issues. So the classical report in a primary hypothyroidism is that the TSH is elevated, the FT4 and the T4 are reduced, and the free T3 and T3 measurements are usually normal and hence of no value here. So for primary purpose, for cases of primary hypothyroidism, only FT4 and TSH would suffice. Now next is a subclinical hypothyroidism. In this case, the TSH is elevated, but the FT4 levels are normal. Most of these patients are asymptomatic and we don't need any treatment for these patients. The only thing that needs to be done is that we need to monitor the TSH levels annually, but many general physicians are very trigger happy and ignorant of this phenomenon and are grossly over treating subclinical hypothyroid patients currently. There are few conditions where you need to treat patients of subclinical hypothyroidism. They are primarily when there is an increased risk of progression seen in patients whose TSH levels are more than 10, females more than 50 years, high titers of anti-TPO antibody, presence of goiter. Patients of dyslipidemia alone need treatment for subclinical hypothyroidism because just by giving replacement therapy, total cholesterol levels can be reduced. All symptomatic patients needs to be treated, and there are certain conditions which also need to be treated like pregnancy, infertility and ovulatory dysfunction. So barring this subset, all other patients of subclinical hypothyroidism don't need any treatment. So 5% of general population are having subclinical hypothyroidism, that's a big number. And 15% of all women more than 65 years of age are also suffering for hypothyroidism. Detecting subclinical hypothyroidism in pregnancy is highly essential. As I told, that pregnancy is one of the conditions where you do need to treat subclinical hypothyroidism, and in this TSH and FT4 are routinely done in pregnant women at the beginning of each trimester. So pregnancy and thyroid is a special condition which I will discuss a little later. Next, hypothyroidism and hypercholesterolemia. 14% of patients with elevated cholesterol have hypothyroidism, but 90% of patients with overt hypothyroidism have increased cholesterol and or triglyceride. So pretty much in all patients where you detect hypothyroidism, a lipid profile must be done. Now the most common treatment given for primary hypothyroidism is levothyroxine or T4 that is available across many brands. T3 is not given, but 85% of the T3 comes from T4 conversion in the periphery. And all patients are made euthyroid biochemically. Most but not all patients feel normal. So average dose is 1.6 microgram per kg. For patients who are more than 50-60 years or patients who have got a pre-existing cardiac disease, we must start with a low dose to prevent the cardiac side effects of the levothyroxine. We should recheck the TSH levels every 4 to 6 weeks after we change a dose, and aim is for a normal TSH level. Now this normal TSH level is also different from the biological reference interval. Usually the aim of the treatment is to keep TSH between 0.5 and 2.5 and not 5. So if the level are more than 2.5, the patient is undertreated, and if the levels are less than 0.5, the patient is overtreated. So this is an algorithm of hypothyroidism. We first measure the TSH, and if the TSH is elevated, we then measure the FT4 levels. And if the FT4 levels are low, this is a case of primary hypothyroidism, we will do the thyroid antibodies. And if the TPO is elevated, it is Hashimoto. If it is we will give T4 repletion. If it is negative, it is other cases of primary hypothyroidism, again T4 repletion. But the importance of doing the TPO levels is that we need to establish Hashimoto, as Dr. Sen had shown in one of his slides, that in Hashimoto the patient can fluctuate from hypothyroid to euthyroid to hyperthyroidism, and the monitoring needs to be more stringent, and there are some prognostic significance of Hashimoto. It can be associated with other autoimmune diseases, with certain kind of lymphomas. So Hashimoto has to be detected first up in all cases of primary hypothyroidism. So if the FT4 is normal, it is subclinical hypothyroid, and if the TPO is positive, again T4 repletion, and if it is negative, the patient is kept on annual follow-up and no treatment is given. On the contrary, if the TSH levels are normal and we are considering a pituitary gland, if you are not considering, then no test is needed, it is pretty much normal. If you are considering pituitary gland, then we will measure the FT4 as well, because in a case of secondary hypothyroidism, TSH is not that useful. And if the FT4 are normal, no tests are required, and if the FT4 levels are low, we need to evaluate pituitary, we should evaluate for sick euthyroid or non-thyroid illness and the effect of drugs. So it's a slightly complicated algorithm, but we'll try and make it simple by a game in the end. So next, coming to hyperthyroidism, the most common causes of hyperthyroidism are Graves' disease, Plummer's nodule, toxic multinodular goiter, thyroiditis, factitious hyperthyroidism, drug-induced, especially iodine, amiodarone and lithium, and secondary hyperthyroidism, which is according to the pituitary hypothalamic origin. So in primary hyperthyroidism, the TSH is usually decreased and the FT3 and FT4 levels are increased. In a very small percentage of hyperthyroid patients, the T4, FT4 levels will be completely normal, but the T3, FT3 levels will be elevated. This condition is known as T3 thyrotoxicosis. For this reason, unlike primary hypothyroidism, here we need to check with both FT3 and FT4 and not just FT4, so that we don't miss out the patients of T3 thyrotoxicosis. So in a toxic multinodular goiter, there can be subclinical hypothyroidism or mild thyrotoxicosis. The common symptoms are atrial fibrillation, palpitation, tachycardia, tremor, nervousness, weight loss, and we can give anti-thyroid drugs with combination of beta blockers, or we can give radioiodine to decrease the mass of goiter, and in some very large goiters, a surgery may be indicated. So in a subclinical hyperthyroidism, the TSH levels is low, but the FT4 and FT3 levels are normal, and usually they don't progress to overt hyperthyroidism, except cases of toxic multinodular goiter and toxic adenoma, where the rate of progression is about 5% per year. There is a subset of patients, however, which need medication just like subclinical hypothyroidism. So any patient of cardiac disease, any patient more than 60 years, patient with pre-existing toxic multinodular goiter or toxic adenoma, and patient of osteoporosis. So these are the indications for treatment of subclinical hyperthyroidism.
Dr. Suri, you have 2 minutes left.
Okay, sorry, I'll try to be fast. So this is an algorithm of diagnosing hyperthyroidism. So we see signs and symptoms of hyperthyroidism, we measure the TSH levels. If they are reduced, we measure FT4 levels. If they are normal, we measure FT3. And if the FT3 is normal, this is the case of subclinical hyperthyroidism. However, if this FT3 is elevated, it is T3 toxicosis. If FT4 is high, this is primary hyperthyroidism. We measure the thyroid uptake. If it is low, we will do the thyroglobulin. If the thyroglobulin is decreased, it is exogenous hormone. However, if it is increased, it is thyroiditis or iodine exposure. But if the thyroid uptake is high, we will look for the pattern. If it is diffuse, it is Graves. If it is nodular, it is multiple areas, it is toxic multinodular. If it is single, it is toxic adenoma. And if the TSH levels are high, which is rare, we will measure the FT4 levels. If it is high, this is a case of secondary hyperthyroidism. Sorry. So thyroid antibodies, they are usually tested to diagnose thyroiditis and for diagnosis of Graves' disease and also prediction of postpartum Graves' disease. Hashimoto I have already covered. Now thyroid and pregnancy. There is increased estrogen levels in pregnancy, hence there is increase of thyroid binding globulin. Because of that, the T3, T4 levels are high even when the FT3, FT4 are normal and the gland is perfectly normal. The HCG levels peak at the end of first trimester, which is a weak TSH agonist, so may cause slight goiter and cause slight feedback inhibition of T4, T3 and hypothyroidism. So all patients who have pre-existing thyroid illness will need increase of 25 to 50% dosage of their levothyroxine because of the increase of thyroid binding globulin. Postpartum thyroiditis is again seen in 5% of postpartum women. Most common it is Hashimoto's, and about 25 to 50% they can have persistent hypothyroidism. So limitation of thyroid glands we've already discussed. There is circadian rhythm, there is diurnal variation, there is inter-assay variation between different assays, and even within the same laboratory if you are using different instrumentation, the levels can vary from 30 to 50%. So as I just said that clinical laboratory tests performed by different laboratories can have different results because of all of these reasons. So now let's just play a game in the end. It is called the 9 square game. Basically it will help us detect all the 9 different conditions that can be presented in thyroid patients. This game was designed by American Association of Clinical Endocrinologists. So this is the first square here. This is very easy. Both FT4 and TSH are normal. This is a case. Anybody? People are not awake. This is euthyroid. FT4 and TSH both are normal. Next square, TSH is increased but the FT4 is normal. This is a case of? No, FT4 is low, sorry. FT4 is low. It is not subclinical. This is primary hypothyroidism. FT4 is high, TSH is low. This is a case of primary hyperthyroidism, correct? TSH is low, FT4 is also low. Anybody? Yes, this is a case of secondary hypothyroidism. Both FT4 and TSH are elevated. This is the case of secondary hyperthyroidism. Now this is that case that you were talking earlier. FT4 is normal but the TSH is low. This is, yes, this is subclinical hyperthyroidism. Likewise, FT4 is normal and TSH is high. This is a case of subclinical hypothyroidism. FT4 is low and TSH is normal. Sir had shown this case also. This is a case of non-thyroid illness where the FT4 levels are low but the TSH is normal. You will repeat the test after few days, FT4 will become okay. FT4 is high and the TSH is normal. This is something that we encounter in our lab almost every day. Anybody? So it could be non-thyroid illness, but more often than not it is patients who are over-treated on L-troxin. Very often the patients are over-treated, the FT4 levels are high and the TSH levels are normal. So between these 9 squares, pretty much any of the mystery of thyroid illness can be, evaluated. And once you know these 9 squares, pretty much everything that I've said in the last 20 minutes can be summarized with this 9 square test. With these words, I'd like to thank you all, and if there are any questions, I'll be glad to answer.
Thank you, Dr. Suri, for a very informative talk on a very important hormone. So, if there are any questions, you may.
Check. Sir, we have one query from online if time permits. Dr. Ashish Agarwal is asking, Suri sir, have you come across any interference of PTH analog injections used in osteoporosis patient on TSH assay? And he is also sharing a case study. Came across a 60-year-old female, TSH low 0.01, FT3, FT4 normal, patient taking PTH analog injection for osteoporosis. Can you please comment?
I have no experience, but more importantly, this kind of history is not usually shared with us. We are a OPD based clinical laboratory, so wouldn't know unless a clinician would share that information.
We know that in hypothyroidism, you were saying there is hypercholesterolemia, but when we go into the biochemical aspects, cholesterol synthesis, the rate limiting step is HMG-CoA reductase. which requires thyroxine. In hypothyroidism, there is no thyroxine. Despite that, we have a hypercholesterolemia. This question was plaguing me since long. So I thought in this August audience, maybe I will get an answer to this question.
No, I am not aware of the exact mechanism, but this is more I said is an association. So it's a more of a statistical association that virtually in all patients of hypothyroidism, some dyslipidemia is there, whether it could be type 2 hypercholesterolemia or type 4 where triglycerides are elevated. So I wouldn't know the mechanism of action, but this I have seen in a lot of patients. So whenever there is a patient of hypothyroidism or even when there is a patient of dyslipidemia, we would usually advise the vice versa to be done.
And also we have been noticing hypothyroidism in most diabetic patients as well.
Post?
In diabetic patients.
Yeah.
Most diabetic patients are also hypothyroid.
So there is the metabolic syndrome phenomenon, pre-diabetes, dyslipidemia, thyroid, they are all linked. So in all metabolic syndrome, you would find some dyslipidemia along with pre-diabetes, stroke diabetes, fatty liver, PCOD. This is that common metabolic
common syndrome where you can't delineate anything. Thank you.
So any more questions? Yeah.
To add on to Madam's question, how in hyperthyroidism there is hypercholesterolemia? Because as rightly said, HLG-CoA reductase requires thyroid hormone. But if you look into the thyroid action, thyroid is a hormone which is required for oxidation. We know the most important oxidation biochemical reaction is TCA cycle, which starts from the acetyl-CoA. So in hypothyroidism, acetyl-CoA is not oxidized via TCA cycle. So there is accumulation of acetyl-CoA, which is the starting material or the substrate for HLG-CoA. So in hypothyroidism, what happens? Instead of oxidizing, more acetyl-CoA gets accumulated. It is enhancing the pathway entering into the endogenous cholesterol synthesis. That is why we are saying hypercholesterolemia in hypothyroid.
Yeah, exactly, sir. Degradation, I think, may be defective in hypothyroidism. Similarly, hyperthyroidism may be hyperthyroidism, more synthesis and more degradation as well.
Exactly.
Maybe that's the only way we can explain it, but I thought I can get some more information.
In hypothyroidism, there is no BMR because there is no oxidation.
Yeah.
Energy.
Thank you, sir.
Thank you very much. May I request Dr. Ranjana Havaldar to hand over the certificate to Dr. Pradeep Suri, please?
Like